We wanted to thank everyone who submitted an abstract. There were a number of wonderful abstracts submitted to the meeting, and thank you all very much. And we all know how much hard work goes into these, so please take a look around, and the abstracts are of course up for presentation here, and they'll be in the room that we had registration right outside the meeting area. The top 3 abstracts that were submitted were actually selected by the selection committee for presentation this evening. And Tracy will introduce our first speaker.
So the poster that won the top award, the first author is Sinha, and it's being presented by the second author, who's Rohini Bhatia. The title is Comparison of Epidemiological Trends in Presentation of Breast Cancer Among Botswana, South Africa, and the United States. And so we'd like to welcome Rohini up to give us a preview. Thank you, and congratulations.
Thank you so much to the organizers and to ICEC for having us here. My name is Rohini. I'm a 4th-year medical student at the University of Rochester. I'm presenting for Sinha, who's a Radonk resident at UCSF today. I have nothing to disclose. So we know that worldwide breast cancer is the most common cancer among females, with about 2 million new cases and over 500,000 deaths in 2018. And Dr. Yarni talked about a little bit of this today as well, that the outcomes and the effects of breast cancer are unequally distributed among the high-income and the low-income countries. So mortality is much higher in low and middle-income countries than in high-income countries. And recently, breast cancer rates have accelerated more rapidly in low and middle-income countries. In the continent of Africa, breast cancer is the most common cancer in the majority of countries, surpassing cervical cancer in some, and we know that it's a very heterogeneous disease. The benefits of early detection and treatment that we have seen in high-income countries have not been fully realized in a lot of these low and middle-income countries. And I know earlier today we talked about using the word obstacles instead of barriers, and I like that. So some of the obstacles to closing the breast cancer gap include awareness and cultural stigma, right? The health literacy that we talked about among the populations. Access to screening resources. So the distribution of resources is more concentrated and clustered in urban centers. Cost, competing healthcare needs, maternal and child health and infectious disease are still very important in these countries. And how do you kind of frame that to governments and say, hey, this is an important factor as well? And that sort of gets to characterization of the problem. So with all of these obstacles, what is some way that we can help overcome that? And I think one of the really important things we touched on today is characterizing the problem, right? Do we have data to support future interventions? So can we improve our knowledge of the problem? A lot of the data on breast cancer in the continent of Africa, when it talks about sub-Saharan Africa, South Africa is the biggest player in that. And Botswana has a really unique role in adding to that data, but being a separate, unique population. So we did a clinical pathologic data gathering from institutions in Botswana, in South Africa, and then compared that to the NCDB in the United States. And just for some context, Botswana is a country of about 2 million people. It has one of the 3rd highest prevalence of HIV in the world. And South Africa is a much larger population, and they have a HIV prevalence of about 7 million people, which is the largest HIV population in the world. So I want to, oh, these are old slides, that's okay. I want to pull your attention to 4 things on this slide. I know it's a lot, it's a table. But the first is age, and we discussed this earlier. So age at diagnosis is lower among Botswana and South African females than in the United States. The second is hormone status positivity. There's large variance in ER positivity, but the highest is in South Africa and the United States with about 80%, and Botswana about 67%. And then triple negative breast cancer is almost twice as high in Botswana as it is in the US and South Africa. And then sub-Saharan Africa overall presents with advanced stage disease at a higher rate. So when we look at stage specifically, we find that Black patients in sub-Saharan Africa were more likely to present with advanced stage disease than Black patients in the United States. And this suggests that maybe it's more of a sociological problem than an inherent biological disease problem as well. Advanced patients were also presented at a younger age in the United States. In terms of HIV infection, a lot of the data that we had in Botswana was unreported HIV status, but from what we did have, 43% of the breast cancer patients were HIV positive. So that's an interesting tidbit that we'll touch on in a second. Finally, how does ethnicity correlate with receptor status? So in the United States, Black and African American receptor distribution was most similar to Black patients in South Africa and Botswana. And in the triple-negative breast cancers, the US Black population and the Botswana Black population are very similar. So those are sort of the quick takeaways. I'm happy to discuss the results further. Something else that we're looking at specifically and that I find really interesting is HIV and breast cancer. So in the pre-HAART era, breast cancer incidence in HIV populations was low. And this is due to competing illnesses, comorbidities, and some literature suggesting a protective effect of HIV on breast cancer. But in the post-HAART era, with longer life expectancy, the incidence has sort of increased. And there's some literature suggesting that HAART therapy can induce metabolic syndrome, and that also plays a risk factor into breast cancer incidence as well. So I think that this is a really interesting area of research that can be further explored. So in summary, this is probably the first comprehensive assessment of presentation of breast cancer in Botswana and South Africa with comparison to the United States. And the clinical pathological factors at presentation vary widely among these three countries that we looked at. There will need to be further studies to explore so we can have targeted policy and really have treatments directed region specifically. And we've listed some of the areas of further study here as well. So thank you so much to everybody.